Hello.
Sir, we are live now. You can go.
Yeah.
You can start
मॅडम
session.
पल्लवी
Yes.
मॅडम सगळ्यांना म्यूट करा
Yes, sir. Yes, sir.
एक्सेप्ट मीनाक्षी वागले and तमन्ना विदू.
Yes, sir.
Yeah.
You can start, sir. We are live. Thank you.
Hello, good evening. 3-month-old girl, first by birth order, born out of non-consanguineous marriage, resident of and hailing from Nashik, Hindu by religion, STY community, informant being mother, brought with the complaints of yellowish discoloration of skin since day of life 4, cough and cold since 10 days, and increased work of breathing since 6 days. Yellowish discoloration noticed by parents since day of life 4 in eyes first, for which they took the child to some local clinic where blood investigations were done and was told to wait, no intervention was done for it. Then yellowish discoloration gradually progressed to involve face after 1 month and was gradually increasing in intensity. There was no history of staining diapers deep yellow, no history of passing pale colored stools. Over the past 20 days, mother also noticed abdominal distension, which on inquiry is predominant in the upper abdomen, which was insidious in onset and gradually progressive, not associated with periorbital puffiness or dependent edema. There was no history of irritability, feed intolerance, no history of inconsolable cry, persistent vomiting or lethargy, seizures, no history of constipation, no history of recurrent cough and cold, passing oily, bulky stools, no history of bleeding manifestations, no history of crying while micturition, no history of any blood transfusions in family, no history of gallstones or surgery in family, no history of failure to thrive. For past 10 days, child developed cough, wet sounding, non-spasmodic, not associated with any post-operative vomiting, or associated with cold in form of running nose. There's history of increased work of breathing in form of increased rate and chest indrawing. There's no history of decreased oral intake or urine output, no history of fever. For above complaints, child was taken to local hospital, was admitted and received some IV medications for 3 days, and then was brought to Sion Hospital. There's no history of any previous admissions. ANCs registered, 2 ANC scans done, are told to be normal. There's history of fever present in 8 months of gestation, for which she received IV medications for 4 days. No history of rash. TT injections, IFA, and calcium supplements were taken. No history of pruritus or jaundice present in mother. No history of GDM, PIH, or hypothyroidism. Birth history, full term, vaginal delivery, hospital, cried on stimulation after 1 minute. No history of an ICU stay. Breastfeeding started after 1 hour. Jaundice present since day of life 4. Immunized till 1.5 months. Developmentally normal on exclusive breastfeed.
Birth weight you didn't say.
1.9 kgs.
Okay.
Birth weight 1.9 kgs. Developmentally normal on exclusive breastfeeds.
Go back. Second slide. So yellowish discoloration noticed on day 4 of life. So what will be your thoughts? That's the first thing that happened. So probably the mother baby were discharged on day 3 and came back on day 4 saying yellowish discoloration. What are your thoughts?
Can be neonatal jaundice as well. Then
Yeah, so first, what do you want to decide or determine in your mind? Physiological or pathological? What else? How will you decide physiological or pathological?
Pathological, when it is present on day 1, it is pathological. Then
Day 1 means?
day 1 of life.
Yeah, so born at 11 p.m. on 23rd. So 24th morning is day 2 or day 1? So never say day 1, say 24 hours. If it's visible in the first 24 hours, it is pathological. Then?
It is lasting for more than 2 weeks.
Yeah, that is a separate issue that we are not concerned just now. We are concerned just now, okay, the baby is come back for jaundice, what do we do? Right? So which other jaundice is always pathological? One you said was first 24 hours. Conjugated. So how will you find out? On history.
Passing pale stools and urine, passing yellowish urine, basically staining the diapers yellow.
So is pale stool compulsory?
No, sir, not all diseases, sir.
So pale stool is a separate story altogether. If you want to decide conjugated versus unconjugated, your only question is whether the urine is dark yellow in color. Okay. Now day 4 of life, can the urine be dark yellow otherwise?
Can be due to dehydration as well.
How will you differentiate?
The
We are on history only.
activity of child, whether the child is dehydrated, active or not. Accordingly, we can judge whether the patient is dehydrated or it is normal high colored urine.
Something more. This we're talking of a 4-day-old baby, so keep that in mind. You're right, activity of the baby, but something more to differentiate between a dehydrated yellow urine and a conjugated jaundice yellow urine. Good. So what history you want?
Breastfeeding, formula feeding, duration, interval.
How will you judge whether it's enough or no? Means
So-
feeding enough or no?
Ideally, we should weigh the baby after feeds.
Which is not every time possible. No? It's only in hospital. Baby is at home.
The stools adequately.
Okay. What else will you ask about the stool when you're trying to judge adequacy of feed? What happens to the stool if the feed is adequate? So the stool becomes yellow in color from the original black. Okay, what else? So you'll ask everything. How often is the baby feeding at a time? How much is the baby feeding? Is the baby happy after a feed, sleeping for 2 hours, then getting up again? Or it's constantly feeding or constantly sleeping? All these things you will ask, right? Coming back to the thing that on 4th day, you have a baby who's come back saying baby is now yellow. What else will you ask in the history and what else will you look for? We are deciding whether this is physiological or pathological. Suppose the urine is not yellow, but still can there be a problem? Suppose this baby is extremely pale now. Is it a problem or not a problem? Why? So in other words, you have to ask many things to decide whether it's your normal physiological unconjugated jaundice or you are dealing with some problem.
Or even pathological jaundice unconjugated on day 4. Okay, ABO can present rather slowly, and though with RH you may expect a high bilirubin enough to give rise to kernicterus by 72 hours or so. Day 4, and when we say day 4, it's 96 hours rather than day 4. Then ABO can present a little late. This was day 4, am I right?
I think when jaundice is noticed on day 4, it must have been there much earlier. Because it takes time for even a doctor to pick up icterus. So if the mother has noticed it, let's believe it started right at birth. By that I mean first 24 hours, 48 hours. One that presents at that time is almost never direct. It's therefore unconjugated bilirubin. So we get straight off feeling that is unconjugated. Now why should it be unconjugated? So there must be a hemolysis. Why should there be a hemolysis? Almost at birth. So child is born with fetal problem which is now manifesting. So congenital hemolytic problem. The breastfeeding jaundice, then breast milk jaundice takes time to come up. When the physiological jaundice is disappearing, it doesn't disappear at the right time, then you start thinking about that. This day 4 baby is not yet fully established on good feeding. So that's normal. In fact, the mothers hardly secrete milk in the first 2 or 3 days, which means there is hardly a need for breast milk. So where is the breast milk jaundice coming and breastfeeding jaundice coming? So this has to be indirect. Now the question is, does congenital hemolytic anemia present almost at birth? You have seen thalassemia coming at 6 weeks, 8 weeks, even later. Okay. You have seen sickle coming much later, but not like this. Okay. So could it be an incompatibility of the plant? Now, had it been RH, it would have presented much earlier as a severe jaundice. Okay. And therefore, one possibility is there also ABO? Now, if ABO is there, then it might not go very fast down. And in fact, if there is an RH plus ABO, then the jaundice may not even appear. How can it be? One incompatibility gives you severe jaundice, RH. Another ABO gives you also jaundice. And two together don't give jaundice. You should have very severe jaundice. Any thoughts on that? Because of, yeah.
No, any guesses?
Because the antibodies are already forming, no? It's killing all. So ABO incompatibility, neither RH incompatibility, the antibodies are getting destroyed. And therefore, such a combination even may not have jaundice. But that is besides. And we would never know also till we do a blood group. So this must be a slowly coming up hemolysis. ABO is one possibility. Any congenital hemolytic anemia presenting at birth? Excellent.
Hereditary spherocytosis.
So now we are between the two. Okay. Now the question is, jaundice is increasing. So slowly that. The only other cause of jaundice, even at that age, which starts and then starts enlarging, if there is a hematoma somewhere. Okay. And therefore at birth, there could be some injury, hematoma, the blood is right there. And that hemolysis starts causing jaundice. But then the story would have been different. So this is an apparently normal looking child. So at that stage, we want to know that if the jaundice is worsening, what is the state of the baby? Is the baby finding lethargy, not feeding as well as before, has not been gaining weight in the second month or third month? All that would tell us where we are. Is he picking up the milestones as expected, or the weight gain is poor and therefore it? So I think all that could have.
So in between means at 4 days, you said they came back and some investigations were done and they were told to wait. So in between that jaundice disappeared.
Continuously increased till 1 month to involve phase also and intensity also.
There was no disappearance. It just kept on increasing and they came back at 1 month because now the face was also in, right? Okay.
3 months for the respiratory complaints.
The increase has been noticed at by 1 month, it had involved the face. Acha, but they came directly at 3 months. So for all these 3 months, they didn't seek any advice.
Point is that if it's slowly worsening of a hemolysis, then anemia would have been a presenting feature more than jaundice. So the question is again that they're saying that it is seen in the eyes also. Otherwise, the severe anemia has a yellowish hue, and the parents feel that it's icterus, it's jaundice, but the eyes are not jaundice. So it is little intriguing that It should have hemolytic problem should have presented with jaundice and anemia only in ABO, where the that too little early because the hemoglobin is very high to begin with, but starts falling down. So the question is how much we rely on this whole story. We will rely first. We're not doubting the story, but it doesn't fit in our thinking process.
Also, sir, if it is increased so much and they didn't seek any attention in the 3 months is also a little odd.
That's right. That's right. And still the urine is not high colored, right? Yeah. So uh, I don't see any. So we'll have to wait and watch
So
and see.
suppose,
But
as sir said, imagine that this story is right, that urine is not high colored and the jaundice has been increasing as per what they are saying. For 1 minute exercise your thoughts, what could it
what
be?
else could be? And the patient is all right. Baby is all right. So could it be Kriegler type 2? Slowly worsening, but not disturbing the health of the baby at all. And I've seen a baby I've seen a child, older child, who is deep yellow with 50, 60 milligrams of bilirubin. She's absolutely fine because the bilirubin started rising a little later than a blood-brain barrier was already mature. So there was no neurological damage, unlike in Kriegler type 1, where there would be a severe neurological damage. And this girl came almost at the marriageable level and asked me whether she could marry and what would be the progeny of life. Because wherever she goes, they would not believe that she is normal, deep yellow person. That's Kriegler type 2. Are we heading for that kind of a thing if there is no anemia? But now, subsequently, you said there is an abdominal distension coming up, but it was not there earlier. So now, how do you put that? We are talking about indirect, unconjugated. Now you have a liver. Can you connect hemolytic jaundice with liver? Not difficult. Give a thought. Spleen, we don't know. Okay. It will not come easily on history, but looks like the liver has come. So could hemolytic anemia come with hepatomegaly as well?
Which hemolytic anemia? Thalassemia. And what is the problem?
There is no jaundice in thalassemia. Why is no jaundice? Thalassemia is the severe form of hemolysis where RBC life is much low, maybe 30, 40 instead of 120.
Destruction happens in the bone marrow only.
Absolutely. Before hemoglobinization, the destruction has occurred. So this is not thalassemia. Then why should there be a liver? So I'll give you a clue. Can liver be there in anemia? Why? What has got that to? Forget the.
CCF.
Congestive cardiac failure.
Okay. So whether there's a cardiac failure coming and the liver is increasing. So I think we'll look at it when you give us something more on that.
And so this was about assuming that it is physiologic array, it is unconjugated jaundice.
You said no dependent edema. The baby is not still dependent on standing, no? So maybe you could.
Sacral edema.
Yeah, but sacral edema is almost.
Also, yeah.
Nobody has almost seen sacral edema. And we don't look at sacrum at all first. So you're right. But just take a note of that, right?
Now, on the other side, suppose that high colored urine they've not noticed or whatever. I'm just discussing. And suppose this is conjugated jaundice. Is that a possibility? And if so, absence of pale colored stools, does it rule it out? Or
Absence of pale colored stools just ruled out the biliary atresia.
rules out?
Later it can initially pigmented.
Some learning there, that's why. So when suppose other things are fitting in and you are suspecting biliary atresia, but you're not getting history of pale colored stools, does it rule out biliary atresia? Why not? What is the explanation?
There can be a partial obstruction which can cause pressure.
So that
That's
is
the-
different. That we call as paucity of bile ducts. It's not biliary atresia. But even if it's atresia, can you still have some colored stools?
Asia, whether it involves the common bile duct, intrahepatic and extrahepatic.
There's some other explanation. Anybody? So basically, you have the intestinal epithelial cells. They keep shedding and they are loaded with bilirubin. So they coat the outer layer of the stool. So you don't see the white color. Okay, so this is theoretically possible that it's biliary atresia. It is clay colored stool only, but just there is a outer coating of the epithelial cells, right? So that's also. So now ultimately in this child, presently this baby you said has come with some respiratory complaints, right? For the past 10 days, cough, wet sounding, non-spasmodic, associated with runny nose, and increased work of breathing, but no fever. So now what would you think this is? So we discussed cardiac failure. So do you think this could be cardiac failure? So what questions will you ask further? That is now. Ceftriaxone has been given now because of these respiratory complaints. So that is a theoretical thing that ceftriaxone causes biliary sludging and all that. But this is all now. It's not all along 3 months, no? How do you ask for history of failure in a left to right shunt? What do you ask?
Forehead sweating,
Is it there?
Suck cycle.
Feeding difficulty. So is it there?
No.
Even in these respiratory complaints, baby is feeding well. Baby is feeding well, that is important, right? So baby is not so breathless. Baby can't feed well. Okay. So we don't know much what this present respiratory complaints mean. Okay. And you said 1.9 kg, but full term. So full term, but 1.9 kg. So would that in any way contribute to the jaundice?
intrauterine infections can cause.
So, okay. So can this be a intrauterine infection? So how will you further discuss points for or against? So some history which will help for, and suppose something is there, whether it can go against. So you want to know the growth of the baby after birth. How is the growth as per the mother? Gaining weight well.
Gaining weight well now is 3.6 kgs. So in 3 months, he has gained weight properly.
So 3.6 means 1.7 kg gain in 3 months. Complete 3 months. So 1.7 is not very great. I mean, compared to 1.9, but that was a full term. That was not preterm. Okay. And feeding well, not irritable, nothing. Sir, congenital infection.
I think congenital infection don't cause hemolysis. They cause a hepatocyte disease. So that is number one. Second is that you have 1.7 kg weight gain, but if it's full term and still low birth weight, then that's not too bad because appropriate for gestational age would have started picking up early. But a full term and low birth weight would take time to pick up. So we could have been better off when we examine the length, head circumference, then we would know all that. So I think for a while we will take that measurement as baby doing all right. But more than just the weight, we want to be sure about the baby's behavior, feeding, sleeping. And if that is all right, then I think we are not really worried about weight. Of course, at 3 months of age, you must also have looked at an early milestones, and they are also fine. So it tells you that this is not a multi-system involvement, which is would have been in a congenital infection, where it is not only one, but neonatal hepatitis is a fatal infection, and there are no other organs involved. But the story starts very early and failure to thrive, whereas all other infections are multi-system largely. Of course, one system may present for a while, another system may appear. But as of now, I don't think it's a congenital infection.
Immunized till 1.5 months, developmentally normal, on exclusive breastfeed, belongs to upper lower socioeconomic status according to modified Kupuswamy scale. A 3-month-old female child, firstborn out of non-consanguineous marriage, presented with the history of jaundice, abdominal distension, predominantly in upper part, small for gestation age, with pigmented stools. Partially immunized on exclusively breastfed, non-sick child with acute respiratory complaints is mostly a case of neonatal cholestasis without coagulopathy or encephalopathy with superadded LRTI to rule out intrauterine infections, neonatal hepatitis, and PFIC.
Yeah, so that was my question, that you've said mostly a case of neonatal cholestasis. So the word neonatal cholestasis is used for direct or for indirect?
Direct.
Direct. So on history, do we have any suggestion that this is direct? Anything to point to direct on history? We don't have high colored urine, we don't have clay colored stools, right? So if that history is to be believed, then we don't have enough to call it direct. So we will not be able to use the word neonatal cholestasis.
Down in health. All these conditions would not do well if neonatal hepatitis, they're all sick babies and they won't go. So I think if you're sure is otherwise all right, feeding well, milestones are all right, then I think all that looks to be unlikely. But the first point that he made is we are discussing unconjugated, and your diagnosis probabilities are all conjugated. So the question is again, has the mother misinterpreted, which is unusual because the dark urine is the first symptom that they say about. So we would rather believe that. And if that is so, then this is not. You agree to that?
Yes. So we'll have to assume for the time being at least unconjugated and try and explain on basis of unconjugated, like regular nurture type 2 or other disease. And then we now need to try to interpret the respiratory or cardio. In this age, we never call respiratory cardiorespiratory because they can present in a similar fashion. So increasing breathlessness, cough without fever. And we don't know whether the hepatomegaly was there a little earlier. That means the child had been on cardiac failure earlier and now it is little more prominent. But today's complaints are definitely respiratory, maybe cardiac and then respiratory, or maybe primary respiratory. In primary respiratory, cough and fever would have been more prominent. And for that, baby should have been more breathless by now, primary respiratory. But if it is not so breathless, then cardiac and then secondary respiratory is more likely.
Earlier, we used to use the term inspissated bile syndrome. It starts with hemolysis. So it's an hemolytic, but to it, a direct bilirubin is further added. But I think that term no longer is acceptable. And I don't know why earlier it was acceptable and now it is not acceptable. Is it an advanced medicine or is it an advanced our poor knowledge? So I don't find any reason for anybody to saying why inspissated bile syndrome is put in the textbooks also. And now we are told that that is obsolete. So we don't know why it became obsolete suddenly.
So what what we are explaining to you as students, what you have to understand is that things are not correlating. So something is wrong somewhere. Either the mother has not seen the dark urine, that is one which sir said is less likely, but theoretically one possibility is that means it's conjugated jaundice. Or then your judgment that the baby is doing well, feeding well is wrong. So some of the things are not fitting in. That is the thing to be learned. Okay, then on examination we'll know. Baby is here.
I think what is more important is when things don't match, it's time to get back to the mother and ask for more detailed questions. And even routinely, I think questioning the mother is not a simple problem. You need a lot of thinking. And we always use the term a thought in action. By thought in action, we mean I ask first question, to which she answers, and that answer leads me to another question. So here you ask, what's the color of the urine? He said, no, it's not high colored. Is it colorless? Is it like water? Then she said, no, it's not like water. Then what is it? So I think if you start inquiring like this, then water she knows is colorless. So then she would have said, no, not like water. Then what? Then at that age to be dehydrated, the child would have been irritable, hungry, not feeding. If that is not, then possibly there is already a high colored urine. I think this is how the history can pick it up. You are right that she told you this and you have accepted it. And that's why many students start telling us that history taken from the mother reliable. Now, this is not reliable because you have not asked details. So keep that in mind. If this comes to be direct bilirubin, it has taught us a great deal how direct bilirubin and dark yellow current the mother has failed to notice. Little difficult to understand. Mother is never wrong. You and me may be right or wrong. So I think you have to believe the mother, but you have to ask her in a different way, right? If she says the baby is all right, so is she happy all the time? Is she irritable? Does she want the feed and then give it up? Again, cry for a while. Then at that stage, how is the urine? Is it enough quantity? All that would have made a difference in the history. So history taking is most difficult. Let's see what it is.
Someone else come ahead. Come, tell us what you see.
The baby is irritable at the moment. Well grown.
Come this side. Stand here also. Come.
इसके साथ बात करते रहो.
The child is having respiratory distress in the form of subcostal and intercostal retractions. The head shape seems to be normal. There is a jaundice or icterus present on the face and in the eyes. The abdomen is involved. There's a slight nasal bridge depression seen. Very coarse facies. The abdomen is distended, but the flanks appear to be normal, not full. No obvious rash. The child is pale, sir. That is present, sir.
कब दूध पिलाने का टाइम हुआ है क्या? हाँ हाँ, तो जरा 5 मिनट दूध पिला के आओ.
पीते पीते सांस लगती है, छोड़ देती है, फिर से पीती है, फिर सांस लगती है। ऐसे होता है कि एक दफा पीना शुरू किया, बराबर पीती है।
दूध पिलाओ और फिर देखते हैं। This doesn't look like a cry of any irritability. This looks like a cry of hunger only. You can distract the baby for a few seconds and then the baby gets back again. I'm sure once she puts the baby to the breast, the baby will be quiet. So irritability is not an issue. Is irritability in jaundice an important symptom? What does it suggest?
It can be due to pruritus, intracranial lead due to coagulopathy. The liver is present around 7 centimeter and 7 and below span is 10 centimeter. Spleen is there 3.5 centimeter and liver is firm, spleen is firm.
Possibly the person who has put this on chat feels that hemolysis cannot go on for a long time. Okay. Do you think, what is your comment on that? So the point is that if the hemolysis is occurring slowly, like Crigler-Najjar type 2, as I said, is severely jaundiced for a life also. So it's not that it is not that. But spherocytosis, unlikely the jaundice will go on increasing. The jaundice is minimal in spherocytosis. Anemia is more often. But Crigler-Najjar type. But it looks like now that we are going to head to direct bilirubin. Okay. With large liver, large spleen. Okay. And even then, if the child is feeding well, then that's quite unusual for any of those liver disorders. But anyway, let's see what we are going to see.
Anthro is normal. And
Normal as in just tell us again.
length is 52 centimeter between 0 to -1 standard deviation. Weight is 3.6 kgs. 0 to -1. Head circumference is between 0 to -1 standard deviation and
What charts you have used to?
WHO growth charts. WHO growth charts. The
Oh, means the regular ones. What I mean is at 3 months, how can 52 centimeters be 0 to -1?
35 centimeters of head.
If you are using the normal WHO growth charts for normal full-term babies, at 3 months, the length is supposed to be 58, 57, 58 centimeters. 52 cannot be just 0 to 50 is normal at birth, no? So in 3 months, only 2 centimeter has increased. That's not possible.
So I think if the length is so small, then I got a diagnosis of hypothyroid. Your comment?
Hypothyroidism
Hold close, hold like this. Yeah,
length is affected more than weight.
correct. So sir is saying because length is affected, can this be hypothyroid? So think of what else do hypothyroid babies come with at this age, and then
No history of constipation. There is no history of constipation, hoarse cry.
like them, like them.
There was no umbilical hernia on.
There is umbilical hernia.
There is umbilical hernia, so all the more.
Photonia or lethargy. The developmental delay is not there.
So most important is lethargy, developmental delay, feeding difficulty at such a young age, right? And then the other things. Okay. So just check on your this thing deviations, but that is not correct.
On inspection, abdomen is distended, flanks appear free, umbilical hernia is there, abdominal thoracic type of breathing, and no visible dilated veins, scars, or pulsation seen. Palpation, there's no tenderness or guarding present. Liver is palpable 6.5 centimeter below right subcostal margin along the midclavicular line. Firm in consistency, smooth surface and rounded borders. Spleen is palpable 3.5 centimeter below left subcostal margin, firm in consistency. Liver span is 10 centimeter. Dull note is heard over liver organomegaly and tympanic note is heard. Bowel sounds heard. On respiratory system, tachypnea, SCR, and ICR was also there. Air entry bilaterally equal, Krebs and V's present. Test systemic examination within normal limits. 3-month-old female child, firstborn, out of non-consanguineous marriage, presented with the history of jaundice, small for gestation age with ANC history of fever with pigmented stools, partially immunized on exclusively breastfeed, non-sick child with hepatosplenomegaly, with adequate weight gain, with LRTI, without dysmorphic features or coagulopathy, encephalopathy, portal hypertension. As a case of neonatal cholestasis without any complications, most likely etiology being hepatocellular with LRTI. To rule out.
So again, to repeat that when you say most likely etiology being hepatocellular, so what are the clinical indicators that there is hepatocyte affection? So what all do we look for to call it hepatocyte affection? Normally, what do we look for?
To rule out obstructive.
No, agreed. I'm just saying that we can't, from the thing that we have got, it is difficult to say that this is hepatocellular affection. What do we normally look for? In a newborn or an infant baby, what do we say this is a sign of hepatocellular dysfunction?
Coagulopathy, sickness,
The
encephalopathy.
coagulopathy is liver failure. Sickness. So you are saying baby is not sick, correct? Then feeding and growth. So not feeding well, not growing well. We are saying baby is feeding okay, growing okay. Then conjugated jaundice, not unconjugated. Conjugated jaundice is a sign of liver disease. I'm just explaining that we don't seem to have anything to justify that hepatocellular is involved. On labs, we may get a mixed jaundice that is different, but clinically, we are having a difficulty explaining. That's what I'm trying to explain. Understand?
Biliary atresia. The babies of biliary atresia may not be very sick looking in the initial phase. They may well get sick when the bilirubin starts bothering the hepatocytes also. But till then, they are reasonably fine feeding well. Do you think it can fit in a biliary atresia?
Pigmented stools and
But
no.
the urine is also not the color. So, and he already said our stool could be falsely pigmented, where the core of the stool may be white. In fact, the gastroenterologists have always said that you must screen the stool really.
They want to see the stool. They want the parents to bring the stool and they will dissect and see whether inside out it is white. They will at this age, there may be little prolonged jaundice. Your older children will not come with jaundice, and of course, other symptoms. Only things as I was just wondering that there can be degrees of hypothyroid, and a mild hypothyroidism may fool us if you look at the earlier part of the development and all. And by 1 year, 7 months, 8 months, 9 months, you, I think, have seen a child who presented who was hypothyroid.
Yeah.
But the development was normal.
Yeah.
At 1 year, it was
Oh, yes. I mean, I've seen a normal height in a very badly constipated hypothyroid. So, yeah, but the point I want to make is hypothyroid, congenital hypothyroid never presents with jaundice as the first symptom. Jaundice appears.
पेशाब का रंग कैसा है? बहुत पीला है कि हाँ हल्का पीला है कि एकदम बहुत पीला है?
हल्दी जैसा पीला है, कभी हल्दी जैसा पीला था ही नहीं।
अच्छा,
लेकिन कभी हमेशा सफेद रहता है कि हमेशा थोड़ा पीला तो रहता ही।
कभी सफेद पेशाब होता है? सफेद नहीं होता है, पीला ही होता है।
Always ask whether it is like water. That's the only color they know. And women, they say, no, not like water. Take it as a colored urine. Yeah. But does urobilinogen not color the urine? In hemolysis, you have increased urobilinogen. Don't you think it should color the urine? It hardly makes a difference as far as urine is concerned, though urobilinogen is increased, but it does not impart much color to go by. So now she says that the urine was always yellow, whether mildly or severely. The whole discussion then changes totally. And now, if that is so, you tell us how will you put all these three as most likely thing.
So just 1 minute before that, so everyone can see the respiratory distress come. What retractions can you see? Subcostal retractions, which means what?
Lower airway.
Lower airway obstruction.
Airway expiratory obstruction.
Okay. So now means I'm just testing you. So in the exam, I will show you this baby, no history, nothing. I will ask you, what do you think? This is a pneumonia or no? What's your answer? Why not?
Because it is not involving the parenchyma, it is involving the lower airway.
How do you know it's not involving the parenchyma? Good, you're right. How do you know?
Because of the subcostal retraction.
Yeah, take a look at it. So no intercostal retractions, and like 5 minutes back, with such a fast respiratory rate, the baby was relatively comfortable, not sick. That is against the parenchymal disease.
But last week's cardiac case, we said comfortable tachypnea is always cardiac. And now he's saying comfortable tachypnea is also respiratory. Do you believe in him? The point is that the comfortable tachypnea is seen in a little chronic bronchiolitis. Okay. The child manages to feed, but still is tachypnic. And that is what is looking like that. And in a bronchiolitis, there is an obstruction expiratory more than inspiratory. The baby can take in air, but when the baby leaves air passively, there is a swelling of those bronchioles. So I think this is typically a recovering bronchiolitis, I would say. The baby must be getting better.
So now sir is asking to debate between these three diagnoses. More likely, less likely, for, against, whatever, everybody. You also say.
The SGA with the hepatosplenomegaly and is going towards
So you are saying intrauterine infection is higher because it is SG at birth and because there is hepatosplenomegaly. Okay.
I think the most reason to debate that it's intrauterine infection is that the infections intrauterine may present with damage, but not active infection. There's a small difference between the two. If the infection is active, the child is sick. But infection has already died out, then the child presents with a damage caused by that. And I think that is important. And therefore, this child may have had a disease intrauterine which has already recovered either by itself because no intervention was done. So then my question is, which such infections would just disappear by themselves? After all viral infections get better. So can CMV do that? Can herpes do that? Means give a thought to that. I think any one of them can do that. Even it's not rare to see a congenital infection coming only with some small organ affection little later in life. So the only argument in favor of that is the infection is already died out and a damage is there and the damage seems to be not recovering, but maybe over time might recover because neonatal hepatitis also not necessarily goes downhill. It starts worsening for a while and then the nature starts even controlling it. Therefore, this one. The point is, what is neonatal hepatitis? It is a congenital infection, but we don't take it as torch. Okay, but very much it's a fetal infection, and today we know that the biliary atresia and neonatal hepatitis are just the same illness. One takes away the hepatocytes first, and another affects the biliary system first. Ultimately, both will have a hepatocellular disease. And I think that's why between your first and second, neonatal hepatitis may still stand. After all, congenital infection causing jaundice is also neonatal hepatitis. But the PFIC looks very unlikely to me. Whatever little I've seen PFIC, the children are all right for the first few weeks or first few days, and then they start gradually. And they're very sick children going downhill. Of course, PFIC is of three types, but anyway, the acute illness is very similar in all types. One type gradually improves, another type improves but recurs, and a third type just goes on worsening. But all of them are sick. So I think PFIC is intrahepatic cholestasis, PFIC is unlikely. Neonatal hepatitis and congenital infection, you're talking the same. And which infection is difficult to get by, but we'll have to see that whether other organs are involved. For example, a child may come with congenital infection with hydrocephalus and jaundice, which I know that, oh, there are two systems involved. So I think this is the way we would go by, right?
And also, so suppose this case were to come in the exam, like we said, there was a inconsistency of the history, it was not fitting in. How do you call it? Conjugated on history. So it was a very big problem. On history, it looked like unconjugated jaundice with hepatomegaly, which is again little difficult to explain. So after examination, at least as sir said, you go back and ask the mother, and then when you are presenting, you will have to present as yellow urine. Otherwise, you will not be able to discuss all this in the exam.
If this baby is 52 centimeters today, and the weight we said is okay for this baby, we might say that this is not short stature, but this may be weight for height nearly fine. If weight for height is nearly fine, then possibly it means that the baby has not much gone down in health and weight parameters, but other extreme is at the extreme of nutritional deficiency, the weight and height might become equal because the weight can go on reducing and height reduces and stops at some stage. So I think by and large, you may have to check whether when you saw the baby from a distance, the muscle mass, subcutaneous fat, everything looked reasonably fine. And I would have called this by stature a small looking child, but not fault, not the FTT or failure to thrive. So that part is right. And if that is so, then my impression is it's a recovering congenital infection, whatever that is. And whether some organ will be damaged or not.
Sir, in differentials, can we put any hemolytic results?
That's the whole point. Now, see, we'll have to take a decision whether you are presenting it as conjugated jaundice or as unconjugated jaundice. If you are presenting it as conjugated, all this stands. And if you are presenting as unconjugated, your differentials will change totally. So explaining unconjugated with hepatomegaly is difficult. You can, which hemolytic will come at this age with hepatosplenomegaly is also difficult. So HS will not come with so much of hepatomegaly at this age. And therefore, some of those metabolic disorders like tyrosinemia and all, they have both indirect and direct. But at some stage, they will have direct. It will not just remain indirect for so long. And then they will have growth failure and all that. So frankly, indirect plus liver spleen is very difficult to explain. So you have to go back and call it direct.
Maybe the question which was asked was, urine बहुत पीला है क्या? If she say बहुत पीला है, then she may expect. Because just now urine पीला है का the answer was straightforward. ये पीला है. And maybe the degree that was important, we didn't say that. That's one possibility. And this particular child has neonatal hepatitis. If it is improving, the hepatosplenomegaly is too much. So this child may still have, if it is a burnt out disease, then we should have had clinically better baby, but I thought the liver and the spleen and the firmness still tells me that the baby's disease may still be active and progressive. Maybe we'll expect something worse to happen.
And was burnt out disease could have a damage which can go on worsening, but not the active infection. And therefore, the baby's feeding will not be disturbed, but the damage done will keep on developing into cirrhosis as well. But I like what you have put in bold. In fact, that's the way you would have summarized in examination. You have perfectly said non-sick child. Okay. And I think I like that bold letters. I thought that was the way you would have said in examination, summarizing it. So take a note of that. That's very good.
Thank you, sir. On investigations, hemoglobin of 9.4, hematocrit 32.6, TLC of 13,200, platelets of 3,24,000. Direct bilirubin is increased. Total is 8 and direct is 5.3. OTPT is 277 and 124. ALP is 2000. Total protein in albumin is 8.1 and 3.9. CRP is 7.5.
1 minute, 1 minute.
There's
Normal
no anemia is there.
for a 3-month-old baby, 9.4.
It is
Not bad.
bad.
It's not in favor of hemolysis.
Normal 3-month-old baby's hemoglobin.
13.
Around 10 only. 3 months to 6 months, they will not have. There is physiological anemia. Then after 6 months, their hemoglobin will start. So hemoglobin okay,
mild
hematocrit
infection.
commensurate, total WC count high, okay.
Conjugated hyperbilirubinemia present. Direct. Should be 20% of the total bilirubin.
Total is 8.
Hmm.
So 2.7 is indirect. 2.7 indirect is also high. What I'm drawing is that this is certainly not just a direct or just indirect, but it's a mixed one. What does it suggest? That liver functions have gone so abnormal that even uptake of bilirubin is also not normal. The excretion is also not normal. Conjugation is also not normal. That is what it is. Comment on OTPT.
So it is raised, matlab, the cells, hepatocytes are. OT is more raised than PT, so it's not liver specific. OT is released by the other.
So that
That is
means
also.
it's likely to be a systemic disorder, and we must find out which other system is involved because the OT is more than PT.
Hmm.
But ALP is high, no?
No.
So it must be a biliary atresia I was talking about.
Any other explanation for ALP high? Comes from the bone also, no? Growing child,
Vitamin D and calcium
vitamin
deficiency.
D deficiency. Okay. So we do, it's not totally obstruction or not just only obstruction, right? And that's why that indirect so much as Sir said. So that takes you to hepatocellular rather than obstructive.
Why globulins are so high? Okay. Globulins are 4.2.
Hmm.
Albumin is 3.9. High globulin. That needs to be assessed. No.
High.
Yeah, it's high. But the point is the ratio. Globulin is higher than albumin.
Is contributed to largely by high globulin.
Hmm.
To check it again, that's
Hmm.
number one. But we may give a lot of credence to increased globulin. Normally, increased globulin suggests an immune response, but in this cell, we are not anticipating that kind of a thing. So we might have to check on that whether that is right or some mistake, or then we have to look at whether any syndrome can have a little globulin high, etc. I have no idea.
Saying in older babies, we would have thought of autoimmune hepatitis, but not at this age.
RFT is normal. PTINR is also within normal range. Peripheral smear showed no evidence of hemolysis, and retic count is also 0.4. Triple H is negative. GGT is 62.5, which is normal for age. USG abdo suggested only hepatosplenomegaly, and Doppler was also normal. Thyroid profile was also done, which is also normal. And torch titers came to be positive, which is CMV positive. Uh, 0.2.
I think this is the age, 3 months, where it's very difficult to kind of correlate between that serology and that. But whatever is still there, your IgM is high, no? So when did this child get an CMV infection? Congenital? The M should have disappeared by now, and G would have gone up, and they're here. Both are almost equal. So why should IgM persist for 3 months, having come out of congenital infection? So we need, there is always a possibility of some laboratory error as well. We don't deny that. But the point is, at 3 months of age, it's very difficult to pinpoint that congenital infection. And one thing to be done is that do the mothers also. And if this baby has X amount of the typical IgG, and the mother has even much higher, then we know that mother is holding it for a long time and the child is holding it for some time. but that IgM should have gone down even to 0 by then. Some antibodies do remain for a long time, but I think 3 months is long enough for M to still persist and equal almost. But mothers has to be done. And if mothers is negative, then you don't even bother about that at all. Mother has to be positive and very likely positive, even less than the baby, because the baby has got recent infection. So the baby should have mounted up much higher antibody titers. So, but these are difficult things to go by. So at 3 months of age, a
No,
congenital
not
infection is
yet.
not easy.
They've sent the CMV, PCR, and liver
Urine.
urine.
Urine for
Urine,
PCR?
CMV, PCR. Report is awaited.
So what else will you check in this baby? Since you are thinking, so this you are thinking is congenital CMV infection, right? Or acquired?
IgM should have been actually vanished.
No,
so-
correct. So as sir said, this could be both congenital or acquired. Now, the thing is that if the baby presented with so much of jaundice, acquired CMV would not present with so much of jaundice.
Day of life 4.
Exactly. So that is there. But then if it is congenital, which are the other organs that may be affected
Active.
subtly? So you have to check. So what do you check in the eyes?
Retinitis,
Yeah.
chororetinitis.
So you got it done? Okay. What about other organs? Which other organs you will check? Huh? USG skull. It's done. Which else? Hearing. So you'll have to look at all the other organs for any damage due to congenital infection.
And if it's all that is normal, then hearing is normal, no heart disease. I think it depends upon what stage of pregnancy the baby gets. Yeah. So the baby, if his mother has been infected just before the delivery, then the baby has got the infection, but the damage that should was that we expect to have occurred for brain and heart and all that period is expected, and it will present something like an acquired disease, but congenital, so to say, starting with that. Maybe perhaps it will present as relatively milder diseases. We don't know how the course of CMV is going to be. Would you like to treat this baby for CMV? IgM positive. I think if the treatment is simple, if IgM is positive, it's worth treating the baby. Maybe to prevent further damage or no, but damage has already set in now. See, some insult may have occurred at earlier part of life. Even if there is no active disease, the damage somehow goes on and on in the liver. Insult at that time, progressive damage still now. Maybe the disease is still active, maybe worth treating, but in spite of treating, I don't know whether we will be able to arrest the progress of the liver. And little more questions when you ask for color yellow hai kya, diaper bhi yellow hai kya, kitna yellow hai वगैरह. Every urine is yellow or no. But somehow we just have this division, yellow colored and not yellow colored. The main thing for unconjugated and conjugate.
Fine. We'll have a second case.
The resident would give some different history. And when I would ask the mother, she would give totally different. I think sometimes the parents also want to fool us to see how much we understand. And but for your this misinterpretation, we got stimulated in our gray cells to say what kind of jaundice should it be. Otherwise, it would have been straightforward a neonatal hepatitis of some kind. So there is always an advantage of even misinterpretation.
There was a question, should we be ruling out biliary atresia in this baby? So the LFT takes us away from biliary atresia because with so much of indirect bilirubin, it's not biliary atresia. And there we would have got, like out of 8, we would have got 7.9 conjugated or something like that. So that is the point.
This is a short 5 months old female child, fifth by birth order, born of non-consanguineous marriage, resident of Bhipandi, hailing from UP, Muslim by religion, brought by and informed by mother, who is reliable, with complaint of cough and cold since 1 week, loose stool since 5 days, increased work of breathing since 1 day. Cough and cold. Cough was weight sounding, non-spasmodic, not associated with night awakening, but was associated with occasional post-processive vomiting. Cold was in form of runny nose initially, later followed by blocked nose. Loose stool, there were 10 to 12 episodes per day, semi-solid in consistency, small quantity greenish in color, non-foul smelling, non-oily, sticky, not associated with blood or mucus in loose stool. Increased work of breathing was in form of increased respiratory rate and chest in drawings. There is history of not gaining weight, history of repeated cough and cold requiring admission, and there is history of cold in the family. There is no history of fever vomiting, no history of bottle feeding, no history of excessive sweating, forehead sweating during feeding, no history of any bluish discoloration of lips or recurrent nebulizations, no history of reduced urine output, no history of no history of similar complaints in the sibling, and no history of swelling over the body. Past history. There was history of admission at 2 months of age for cough cold and increased work of breathing, for which she was admitted for 6 days and required O2 support. Second admission was at 3 months of age for increased work of breathing, cough and cold, which also required O2 support and was admitted 14 days, during which weight of the child was monitored. ANC history, not significant. Birth history, child is a full term, home delivery, uh, cried immediately after birth. Birth weight was 2.7 kg. There is no NICU stay or no neonatal jaundice. Immunization till 1.5 month. Developmental history, gross motor. Child has rollover, fine motor, object transfer from one hand to other hand. Language, child babbles. There is stranger anxiety. Impression wise appropriate for age. Diet history. Child is on exclusive breastfeed, but mother has poor milk output. Summary.
Go back. How old is the baby? Go back first. 5 month
5 month
child.
old.
Come. No, don't. You come here. Okay. So tell us, what will be your thoughts with this history? How will you start thinking?
It is a can be a respiratory infection, a cardiorespiratory infection, cardiac cause. It may be.
No, so what? 1 minute, one by one. Let's go systematic. There is cough and cold, and there is running nose also. So why do you jump to cardiac? Respiratory. So running nose, you have confirmed there is definitely, because see at this age, in early infancy, some like we were discussing, sometimes parents also club the cough and cold together, and we also club the cough and cold together. And it is very important to decide whether there's actually running nose or no, right? Okay, go on.
Noisy breathing and will be called cold.
And then there is loose stools. is, yeah.
Multisystemic involvement is also mostly viral.
Okay, so mostly viral, but what is missing to call it a viral? There's no fever only, right? So now again, whenever there is an infant in whom you get this history of loose stool also, what are the other questions you should ask? Can an infant normally pass 10 motions? Yes. So how will you, so you have to ask what was the normal stooling pattern and has it changed in these 2 days, right? So then you know whether this is different or this is just a variation. Normal was 8 and now it is 10 or 12. That may not mean anything, right?
And many times the baby may just pass a small amount of stool when they pass gas. And they'll go on counting 3, 4, 5 because the baby has passed stool. It's not actually a motion as such. When they pass gas, some leaking is there. So make sure that it's really 10 loose motions.
Now this increased work of breathing is since how many days? This present one? Since 1 day. Okay. So now that is definitely significant. So loose stools, we need more questions. Cough and cold, like we said, the cold, we need more questions. There's definitely coughing. The baby is definitely coughing. Yeah. So definitely coughing and now fast breathing. So now tell us, how will you think various things? It could be respiratory, it could be cardiac. So what all will you think? In respiratory, what can it be? Okay, it can be bronchiolitis. Now, how will you on history confirm, or what more points you want or less points? Normally bronchiolitis has running nose or no? Mild or not there? Okay, then what about fever? Starts with mild fever, but then fever quickly disappears. Okay, cough is more or breathlessness is more?
Breathlessness is
Very good. Breathlessness is more. In fact, cough may not be there at all. Okay. Or it may come later, or those babies who come with recurrent bronchiolitis, they may have a cough, right? So cough is not the prominent feature of bronchiolitis. It's more of breathlessness, right? Then what else can it be? Cough and breathlessness. What else can it be in a infant?
failure.
Yeah, cardiac. Okay. So what will you ask? Decide. You have to decide. No, this is respiratory or cardiac.
Subcycle.
Yeah. Yeah. So how do you ask cycle? What will you ask the mother?
पीते पीते छोड़ देता है, फिर वापस से पीता है, रुकता है क्या बीच बीच में?
Prolonged period of breastfeeding. The child takes small feed, then stops. So the total duration of breastfeeding is more.
You're right, but don't put so many words in the mother's mouth. All this, when you're describing, mother has to just toss a coin in our mind, in her mind, and decide हाँ बोलूं के ना बोलूं, right? You have to have an open-ended question. बच्चा दूध कैसे पीता है, कितनी देर पीता है, कैसे पीता है? Then let her say के छोड़ छोड़ के पीता है. Then it makes it very important, right? Okay.
Recent onset, if the mother is saying abhi chhod ke pita, it can be because of a nose block also.
Yes, yes, it can be, but that's what we talked of, na? Ke in a difference between a respiratory, like a nose block, or a bronchiolitis, and a cardiac. Here, छोड़ने से कुछ फायदा नहीं होता है. In nose block and in bronchiolitis, छोड़ने के बाद there's no benefit because the breathing is still the same, fast only, or nose is still blocked. So he can't feed only. Whereas cardiac में छोड़ने के बाद he gets his breath back. So he is now again able to feed. So that is exactly what you have to fish out from the history. कि छोड़ने से फायदा हुआ कि नहीं. You getting what I'm saying? Okay. Then any other respiratory cause? Cough and breathlessness, infant. Aspiration, no? So how will you say this is not aspiration? Or how will you pick up that this episode looks like aspiration?
Usually, the mother will give history after intake of some breastfeed. The child developed respiratory distress in form of difficulty in breathing.
The duration will be short. Acute present.
This is acute only, na? 1 day breathlessness, you said. So it is a. So again, use common sense. We are just learning how to think. Suppose the baby aspirates. What will happen first? 7 o'clock, the baby aspirated. So what will happen at 7:05? Will the baby become breathless at 7:05?
Loss of consciousness.
Okay, that is if it's a very severe aspiration.
Because there will be decreased activity.
Coughing.
Very good. So the first thing will be a sudden onset severe cough. So that cough is quite prominent because the baby aspirated. So suddenly till 6:55 there was no cough, and at 7:10 there is a lot of cough. So that is the first event. Then that breathlessness takes a little time to come up. It will not be immediate. No, that aspirated milk has to go down and cause chemical pneumonitis or a secondary infection or whatever. Then the baby will become breathless, right? So more prominent cough will tell you this is aspiration with that sudden history.
I think there is no cardiac problem here. It is an immune deficiency. Two systems involved, repeated admissions. First thing is immune deficiency. How can you not think? Cardiac fellows get some loose stools for what? But the immune deficiency fellows get two infections in two different systems and recurrent also. To me, it's an immune deficiency. You have to agree with me. You say maybe both are likely, whatever. Or you can just throw it away. Yes, you can almost throw it away. So now tell us why. Give a thought, give a thought. What is different here that is against immune deficiency? The stools are agreed. That's a good point. But generally, the fever at this age is plus minus, means high fever, yes. But you are right. Absence of fever puts you against infection. Okay. The second is how quickly the baby gets better. Okay. Would the baby get 10 days of IV antibiotics and hospitalization and all that? If not, then it is a self-limiting. You give a rest, give oxygen, send him home. So that is not. Stool is green, no? What is this color? I can understand high-colored urine, but this high-colored stool. What is green stool? Infection. So infection there, infection here. Again, what is green stool? And
In pens, it is usual to have greenish stool.
green stool is starving. Well, if there is a frequency of stools, then there may not be time for the milk to get mixed with bile, but otherwise starving. So this child's intake is less. So why is the intake less? between admissions, he has not been all right. Whereas any infection gets better, even immune deficiency, the child is all right for a while till he gets another infection. Immune deficiency does not mean infection doesn't come under control. It only means infections keep on recurring, but in between, they're all right, asymptomatic. This child seems to be having a poor feeding, and therefore we could have asked about how is this feeding? Does he feed well on breast? All that. Very likely, that is the point that between two episodes of admission for a respiratory distress, this child must have been mildly tachypnic. That brings us to a congenital heart disease.
Okay, now further just some points. You said so.
In a small baby, when he comes with cough and breathlessness, it's always important to make out respiratory or cardiac. And it is not necessarily every time busy. I have some points in mind. A respiratory problem, if it is fever, then well, if there is no fever, the onset should be relatively acute in a respiratory problem, and cough may be much more a prominent symptom. After a variable period of time, when the child is treated, the recovery should be relatively complete in a respiratory problem, while some residual symptoms, especially tachypnea, I give a lot of importance to increased precordial activity, which parents often complain of them, should persist, and then the recovery. So recurrent respiratory infection should have acute onset, a relatively complete recovery, and a recurrence. And a cardiac problem should have a relatively slow, not a very fast onset, and will never get better. Some precordial activity will persist, followed by recurrence. Fever may not be very prominent, but it's not very easy to make out. And in the respiratory, aspirations are, as he said, are massive aspirations. But small, in a VZ child, when we conclude that it is respiratory, in a VZ child with a recurrent V's, the aspirations are very small, micro aspirations, and therefore there may be no such history. But if he's regurgitating, now many babies keep on regurgitating, which we call as normal, but there's a significant regurgitation, and you see little frothy baby, and maybe little forehead sweating as a result of distress. Maybe these 2 points may favor aspiration, but not easy.
I think acute respiratory condition starts with breathlessness and not cough. Whereas a cardiac condition starts with cough and also may be breathless. And again, somebody who starts coughing at two months or few weeks is almost always cardiac till proved otherwise. And acute problem, acute pneumonia has also come with breathlessness. Acute bronchiolitis comes with breathlessness. Whereas aspiration may come out with cough, but there is no fever, and you know it is related to that. So breathlessness as an onset is acute respiratory. Cough as an onset is a congenital heart disease.
Like you had said earlier, in an acute respiratory problem, there is no difficulty in feeling, there is failure to feel. Will not feed. While cardiac feed लेता है, feed पेता है, लेता है. ये feed लेगा ही नहीं. He can't because he's so breathless. Refusal to feed.
Now we have agreed that this looks like a congenital heart disease. So what kind of a heart disease?
Cyanotic heart.
Shunt or no shunt?
Left, right.
Left to right shunt. Okay.
ASD, PDA.
ASD. You're right. Why? That is, we are still not on history.
Because of symptoms.
ASD is usually not presenting. Either it presents in the newborn period or it doesn't present only till later. Good. PDA? More common in? Yeah, but neonate and some category of neonates, you're right. Very good. Preterm. So was this baby preterm? No, this baby was not preterm, right? So for these reasons, VSD more likely. Okay. Only one small thing in development, the others, you find this okay or something is making you get up from your sleep. 5-month-old baby, no?
In the anxiety,
6 months, 6 to 7.
6 or even later, 7. So what does stranger anxiety, can stranger anxiety be very early? When will it be, and can it be very late?
And irritability we interpreted as
She's saying whether irritability was wrongly interpreted as stranger anxiety by the mother. Possible. So stranger anxiety depends on partly on how many members are there in the family. If there's a large family, baby seeing 8, 10 people every day, they will not develop stranger anxiety very early. But if it's just 1 or 2 people, only parents, then they will develop stranger anxiety as soon as they see a third person. So that will be little early. That's what. So there is a lot of disparity, So transfer of objects is usually 6 months, not 5 months. And this is a little sick, repeatedly sick baby. Similarly, stranger anxiety. So they are a little odd, and Babel's is a little too low. He should have gone beyond that. I, you, all that. Yeah.
Summary. 5-month-old female child, with the birth order, born of non-consensual marriage, came with complaint of cough and cold since 1 week, with loose stools since 5 days, and increased work of breathing since 1 day. Uh, uh, with history of failure to gain weight, differential diagnosis being congenital heart disease with increased pulmonary blood flow without any signs of failure. Second, recurrent pneumonia.
So because we discussed there's no fever, you should not give recurrent pneumonia as a differential.
So on examination, child is afebrile with heart rate of 150 per minute and respiratory rate of 54 per minute with subcostal and intercostal retraction. Peripheral pulses well felt. Extremities were warm, saturation 99%. AF was open and at level of 3 into 2 centimeter. Frontal washing was present and pallor was also present. Anthropometry.
Child is there? No.
The child was having distress. Anthropometry. Weight is 3.2 kg, height which is less than 3 standard deviation, and height is 57 centimeter, which is between -3 to -2 standard deviation. Head circumference is 37 centimeter, which is -3 to -2 standard deviation. And there's also mid upper arm circumference, which is 9.5, which is less than -3 standard deviation. Height, weight for height is less than -3 standard deviation. That means the child is FTD. On systemic examination, on inspection, there was no precordial bulge or no apex impulse visible, no visible pulsation or any other scars or sinuses present. On palpation, apex beat was palpable in fourth intercostal space, lateral to mid clavicular line, and no parasternal heave or thrill was present. On auscultation, first heart and second heart sound was heard, and loud P2 was heard in pulmonary area with pansystolic murmur, very pansystolic murmur, which was heard over tricuspid area. Rest system, CNS, tone power reflexes were normal, and respiratory system, air entry was bilaterally equal with Krebs present bilateral. On per abdomen examination, soft, non-tender liver of 2 centimeter and spleen was non-palpable. So the final diagnosis can be a 5-month female child came with complaint of cough, cold, increased work of breathing with palpable P2 and pansystolic murmur heard over tricuspid area in a birth and developmental normal, partially immunized child could be most probably a case of ventricular septal defect.
So, can this be a fallows? Can this be a top?
And stall. If murmur is there, no cyanosis.
No cyanosis, clinically no cyanosis, it's just 5 months. Na, if you do a pulse ox, you'll find that there is some cyanosis. I'm asking you to defend or argue, or because he said P2 also palpable.
Eight times.
Recurrent.
Left right shunt features.
So recurrent breathlessness, cough is a sign of increased pulmonary blood flow, and cough is decreased pulmonary blood flow, right? So that you said loud P2. So that means is this child in pulmonary hypertension?
No, sir. Actually, loud sound was heard around P2 area. I was not confirmed that there is actually sound or not.
Correct. We are just learning. So now suppose you've got a loud sound. Like me, examiner will ask you, is
Okay.
this pulmonary hypertension? So how will you say yes or no? So what are the other signs of pulmonary hypertension? Clinical signs. Right ventricular hypertrophy. So you've got parasternal heave. You have?
No.
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 You get epigastric pulsation.
No pulsations, sir.
Why does pulmonary hypertension happen in a left to right shunt? Too much? Very good. Speak loudly. No, you're always right, but you all don't speak. So too much flow. So have we had enough time for too much flow? No. Is the size of the VSD so big that there is too much flow?
Murmur is heard, then the size is not that big. So
Was there a thrill?
No thrill.
No. So you, in the exam, I'm trying to explain how will you answer pulmonary hypertension. So you'll give all these arguments. So you say maybe it is a thin chest wall. That is why I'm hearing a loud second heart sound. Okay.
I think this child has a microcephaly. You said head circumference -2 to -3 ST. That's microcephaly. The point is, many of these cardiac defects have syndromic nature. So I'm convinced that this child's brain is not normal. And you must tell me whether there was a dysmorphic facies. Microcephaly is there. That means the brain is not developing. So the milestones will not be normal. You said babbles now. Oh, he said that posterior pharyngeal sound should have come up by 5 months, right? So I think this child is already delayed and is syndromic.
First fight against microcephaly.
The chance of brain -3 less than
Minus -2 to
standard
-3 is abnormal.
than equal to or less than -3 standard.
I'm not aware that it has changed. Our concept was it should be less than -3 standard deviations. So that is one. But second answer, sir is saying that this child's brain is affected.
I want you to tell us, how would you judge the head circumference normal or abnormal in infancy? What I'm asking is, yes, exactly. Tell us what's the formula and apply it here and convince me it is not microcephaly. Not because it's -2 or 3, but it, yeah. So if you look at that divided by 2 plus minus, it will not be microcephaly. So that is important, right?
How will you treat this child?
So we have a cardiac disease with plethoric lung fields. Okay. Which ventricle is dominating? There is LV, there is IV, or there is biventricular. So what does your palpation tell you? Apex beat in the mid-clavicular line, outside the clavicular line, lower down. What are the signs? If it is shifted left side, then what ventricle? LV. And if shifted down and out, then? And what are the signs of what I'm trying to tell you is we should be able to, so to say, construct the diagnosis. This child has hyperemic lung fields. So it could be ASD, VSD, PD, ASD, no. So he has a left ventricular predominance. Then PDA is more likely. He has biventricular hypertrophy. Then left ventricle, right ventricle, whether there is pulmonary hypertension, whether the apex beat is hyperdynamic or uh, it is heaving. So every time it may not be very easy, but we'll try to construct in our mind, and then we will see whether we will right or wrong. Okay. So we have these 3 different categories altogether. To gain the book, it is very simple. LV means PDA means LV, biventricular is VC, VSD, RV is ASD, but we try to interpret that.
What is the actual diagnosis in this? Investigations?
Sir, I have only 2D echo report of the child. No further investigation like CBC or Aura. Yes, it is done, sir. No. Yes, there are also mild MR.
Okay, fine. Any questions, any doubts? Online audience, any comments, any questions? Thank you, ma'am. Thank you. So we meet next Thursday. Thank you.